Hello again. Today I will share with you the last part of our IBS sessions delivered by Dr. Neville Azzopardi. Part 5 will be all about pharmacological therapies. I hope you have found these sessions informative and thank you for watching.
So, hello again, and today we'll continue talking a bit more about IBS. Today we'll talk mainly about investigations and specifically on the management of this condition. So investigations. IBS is a diagnosis which can be made based simply on history and examination. Most patients with typical symptoms and with normal examination don't merit further investigations, and the first step should be to recommend lifestyle changes, which we'll get into shortly, and possibly pharmacological therapy. Only if the patient does not respond or if the patient insists, would you consider investigations. And first-line investigations should always be non-invasive. I very, very rarely recommend colonoscopy in these patients unless there is something which is of concern. A number of reasons. Number one, doing a colonoscopy under sedation in these patients tends to be extremely uncomfortable. Number two, it means putting the patient through an invasive test which very frequently they don't need and which will not help. So non-invasive investigations, blood tests, blood count to exclude anemia, particularly in men, because that would worry us a bit more. Celiac test, celiac screen and thyroid function tests are important. C-reactive protein might help. The problem with the blood test, blood inflammatory markers like CRP and DSR is that they are non-specific. So you can have a high CRP in a patient with IBS, and you can have a normal CRP in somebody who has got inflammatory bowel disease. So it's not a test I particularly like, but we do recommend it. Liver and renal profile, but the most important test is probably the stool test, the fecal calprotectin. If you're suspecting, obviously, infections, if a patient has chronic diarrhea, you may want to do stool studies for CNS, OCP, and C. diff. But the fecal calprotectin test is a test which helps me either reassure the patient or else tell them, listen, it's better if we do the colonoscopy. The fecal calprotectin is an inflammatory marker which can be measured, and it tells us a low level basically means that there is no inflammation in the gut. So if the symptoms are very florid, then the symptoms are coming from IBS. If the fecal calprotectin is high, that might indicate that there might be an underlying inflammatory condition, which might be anything from an infection to inflammatory bowel disease and possibly even malignancy. So the fecal calprotectin is usually the marker that I use to decide whether a patient with typical IBS symptoms merits a colonoscopy or not. Low level, less than 50, it's IBS. Anything above 50, you need to consider an endoscopy. Frequently we get borderline tests, anything between 50 and 150. If the history is typical of IBS here, I might consider repeating a second fecal calprotectin test before recommending the endoscopy. But then depends on how anxious the patient is, on what the patient wants to do. I always offer the colonoscopy in these cases. So when to go for an endoscopy? If there's a positive fecal calprotectin, as we said, if there's a family history of colonic tumors, even if the patient is relatively young, we've seen patients with young patients with colorectal cancer, or if the patient is above the age of 50, and here you do it once again to screen for cancer and also to screen for polyps. As you will see, as you can see from this chart, food intolerance tests do not come into the investigation of IBS. Like all other gastroenterologists, like most gastroenterologists in the world, we don't recommend food intolerance tests. I don't think it's a test which helps much, and really the results of the food intolerance tests in most cases mirror the FODMAP diet, which is much cheaper to do and usually gives better results than diets based on the food intolerance tests. But that's as an aside, it's available locally. Some patients opt to do it. There are doctors who recommend it. But as I said, it's not something that is actually recommended in the investigation of IBS, and it's not something that I personally do. What are the possible differential diagnoses? We've mentioned celiac and thyroid problems, diverticular disease, inflammatory bowel disease, malignancy, infections. And finally, I'll talk briefly about lactose intolerance, SIBO, and pelvic inflammatory diseases. Lactose intolerance is extremely common, and I can tell you that most, if not all, patients with irritable bowel syndrome are lactose intolerant. Once a patient presents with symptoms of IBS, simply tell them to get rid of the lactose from their diet, and nearly all patients will improve or will get some improvement. So the question is the patient just lactose intolerant, or is it just IBS? Patients who are just lactose intolerant will improve simply by avoiding lactose. Obviously, patients with IBS need to follow the FODMAP diet, as we shall see. So it's not just avoiding the lactose, but lactose avoidance is part of the FODMAP diet, as we shall see. SIBO refers to small intestinal bacterial overgrowth. This is a terminology which has come forward in the last few years, and basically it describes the growth of certain bacteria in the small intestine, typically after surgeries, after the use of antibiotics, after certain infections. Not easy to treat. I don't think we have the test to check for SIBO locally, but it can be tested. I've had patients who did the test. The problem is that the results are frequently borderline, and most patients who believe that they have SIBO because they spend a long time reading on the internet will actually have IBS. But if you have a patient with SIBO, you might consider using antibiotics like metronidazole or rifaximin. I've had many patients who are basically convinced that they had SIBO. I gave them the antibiotics and they did not improve. And in the end, there was some relief by targeting the symptoms for the IBS that they were actually. Finally, gynae problems, you have to consider these in women, particularly if you have high inflammatory markers, the typical symptoms related to menstruation and to ovulation. So in these patients, we need to consider referral to the gynae. So how to manage the patients? I split this up into 4 parts, but I always tell patients, basically the management of IBS is not just pills. There is no pill which will cure you from IBS. Pills usually hide the symptoms or make you feel a bit better. But if you think that just by popping a pill, you're going to cure yourself from IBS, you're absolutely wrong. Most important things: diet and exercise, lifestyle. These probably represent 60 or 70% of the management of IBS. Drugs help. As I said, they do give some relief. They help in certain conditions, and here we'll be talking briefly on probiotics and also on Energast. But most drugs like antispasmodics, antidiarrheals, laxatives that are used in IBS are there simply for symptom relief. So they don't really affect the underlying pathophysiology, which might be leading to the IBS. Let's start briefly on diet, and I'll just talk briefly on cognitive behavioral therapy as well. So let's talk briefly on diet, okay? The diet that I strongly recommend is the low FODMAP diet, all right? FODMAP diet, you will find lots of apps on the internet. I actually have a document which I give to patients and I explain to patients, because when you start reading on this diet on the internet, you can get very confused and you start believing that you cannot eat out or that you cannot eat most foods, and that's not the case. Really, it's avoiding all the additives and all the preservatives that we are nowadays eating in our diets. 30 years ago, very few patients suffered from IBS. So what has happened now? What has changed in the last 30 years? It's mainly the diet. It's the fact that we are not exercising enough. It's the fact that our lifestyle has changed drastically. We tend to eat everything which is highly processed, ready-made, and we've eliminated all the natural foods from the diet. So what's good? Fresh vegetables and fresh fruit, nearly all good. A few exceptions: we know that mushrooms, broccoli, and cauliflower tend to cause a lot of bloating, so these I would avoid. Fruit-wise, nearly everything is once again good. Usually I recommend patients to eat only small portions of the rich summer fruits that we have in Malta, like watermelon, peaches, pears, because these contain a lot of fructose, which tends to make the IBS worse. But anything else in terms of vegetables and or fruit are usually good. Small note about garlic and onions, which the diet recommends to avoid. I always tell patients, small quantities, if you want to put some garlic and some onions in your pot, should be fine. But don't, don't put 6 or 7 onions in your pot, because then that's going to give you symptoms. Most meat and fish which are fresh, including shellfish, are fine. Eggs are fine, but I always recommend to avoid processed foods, those which contain a lot of additives. So things like sausages, breaded fish and breaded meat, burgers. If you cook the meat, it's better if it's grilled or in the oven or barbecued, rather than meat with a lot of barbecue sauce and other types of sauces added to it. It's the sauce which actually gives the symptoms, it's not the meat. But otherwise, meat and fish are good. Dairy. Now the dairy is, as I said, it's one of the things that I eliminate. So lactose-free diet, I recommend patients to go on to drink lactose-free milk. And some patients cannot tolerate even lactose-free milk. Almond milk and coconut milk are usually fine because they contain absolutely no lactose. But I also tell patients to avoid soya, because soya tends to give a lot of bloating, once again, and a lot of symptoms related to IBS. So lactose and soya, I recommend patients to avoid from the diet. And if you're going to take something, it's the quantity. So if you take some hard cheese, that's usually fine because the amount of lactose that it contains is low. But if you're going to eat something, ricotta pie, for example, the ricotta in itself has a lot of lactose, and that's going to give you symptoms. So ricotta is another thing to avoid. Ice creams, white sauces, strongly advised patients to avoid them. Finally, grains, in particular gluten. So we know that gluten, here we're talking of an intolerance to gluten. This is not an allergy, so we're not talking of celiac. Gluten can cause a lot of symptoms when eaten in larger quantities. So I tell patients you can take a slice or 2 of bread every day, but don't eat a whole bread. Don't eat a whole pizza. Don't eat a whole plate of pasta with white sauce in it, because you're combining the gluten with the lactose. So I tell patients to decrease the quantity of gluten in their diet. They can eat other grains, like, for example, quinoa, like, for example, rice, which is extremely good and which patients can eat without problems. They can eat potatoes, chips, popcorn. All of those are good. Some patients take it a bit drastically and go on a completely gluten-free diet, but I can tell you that very frequently that's not necessary. Besides being expensive, the taste of the food is not exactly the same, and usually just by decreasing the quantity of gluten in the diet and eliminating the lactose, there should be a difference. However, the thing which really makes a big difference is exercise. Okay, I tell patients, the more exercise you do, the more you can eat. Okay, so you can eat a bit more bread if you do more exercise without getting the symptoms. So it's a combination of both. Most types of exercise are good, but in particular, we recommend cardio. So walking, running, swimming, cycling are all good. Probably weightlifting will not help much the IBS, so cardio is essential. And in my opinion, the best type of exercise is walking and jogging. Tends to help the patients a lot. It improves the general well-being of the patients, and the big advantage of the exercise is that it also helps decrease the stress which tends to be associated with the irritable bowel. I want to talk briefly about cognitive behavioral therapy. Some patients who are obviously very anxious might benefit from cognitive behavioral therapy to help decrease their stress, because that has been shown also to improve the symptoms related to IBS. I don't always send them on the first time to a psychologist or to a psychiatrist. But when a patient continues coming back and the patient starts telling me, listen, I'm very anxious, I tell them, listen, I'm not going to give you a lot of aggressive treatment for your anxiety, but probably there are therapies which might help with your IBS simply by dealing with the stress. It's a question of how you put it to the patient. And, there is a lot of evidence to show that cognitive behavioral therapy has a good influence on the gut-brain barrier, on the gut-brain theory, and it has been shown to decrease the symptoms related to IBS. Finally, drugs. What do we have available? We've got probiotics, prebiotics, antispasmodics, antidepressants, bile acid sequestrants, loperamide or Imodium for diarrhea-predominant IBS, and then we've got the laxatives and rifaximin. Let me talk briefly on these, and then I'll explain when they should be introduced. So antispasmodics are obviously very useful for abdominal pain, cramps, and bloating. Probiotics will probably help diarrhea predominant and bloating or cramping predominant IBS. Antidepressants might help most patients, especially those with pain predominant IBS. Cholestyramine is indicated for diarrhea predominant IBS when probiotics haven't helped. And same thing for rifaximin. Rifaximin is an antibiotic which is bowel specific, so it kills only bacteria in the gut. It has been shown to be effective in IBS. The problem is that a few months after you take the course of the rifaximin, the symptoms very frequently come back, so you might need to repeat it. And it's an antibiotic which is given for a period of 2 weeks. Unfortunately, in Malta, you need a special prescription by a gastroenterologist to get this drug, which is ridiculous in my opinion because it's a very safe drug. But it has been shown to help, and I've used it in patients who had very severe symptoms of IBS. But as I said, the relief tends to be temporary. Typically, after using the rifaximin, I then give a course of probiotics to help replenish the healthy bacteria in the intestines. The issue with probiotics, there are different types of probiotics. In my opinion, they all have their benefits. And I don't use long-term probiotics. I usually give a short course for a few weeks, 2 to 4 weeks, and then I recommend the patient to stop the probiotics, and you can repeat another course, possibly a different type of probiotic, maybe a few months down the line, and this might help keep a healthy gut. Finally, in patients with constipation and predominant IBS, diet is crucial and exercise. I strongly recommend this for people who are constipated. They need to avoid the gluten and the lactose. Lactose itself frequently causes diarrhea, but it might also cause constipation. So I cut these from the diet and I tell them to exercise. And that is the most important part in the management. But most patients will need some other type of help. Polyethylene glycol is very useful. Do not use lactulose in patients with IBS because lactulose causes a lot of bloating, a lot of gas, and it can give very bad symptoms with a lot of flatulence. So I don't like using lactulose in IBS because patients tend to feel worse off with it. Finally, let's look a bit at the slide. In patients with mild IBS, education, stress, management of the stress, diet and exercise are probably enough without needing pharmacological therapy. When the symptoms are a bit more severe, when they're affecting the lifestyle a bit more, for constipation predominant IBS, you can consider laxatives like PEG for diarrhea predominant IBS. You can use probiotics and loperamide for symptom relief. And for persistent diarrhea predominant IBS, you will consider drugs like rifaximin, especially locally. For pain-predominant IBS, so for bloating-predominant IBS, you've got the use of antispasmodics and also tricyclic antidepressants and SSRIs. Usually when I'm going to start a tricyclic antidepressant, that is the point where I start recommending a patient to speak to a psychologist or a psychiatrist. Finally, this is a talk which has been sponsored by Energast. A few words about it, though Rachel will be talking in more depth on this new drug. It consists of sodium butyrate. It has a number of uses. It's not just used in IBS. It's also used in diverticular disease. It's also used in patients with chronic diarrhea or traveler's diarrhea. And what it does is it replenishes the levels of sodium butyrate in the gut. And this is a compound which is essential for healthy functioning of the gut. And we know that in IBS, the levels of sodium butyrate tend to be low. It's a longish course of treatment, usually a number of months, but I've had a lot of patients who did improve with this drug. And being a very safe drug with no side effects, a bit like probiotics, I tend to use it first line before I consider other drugs which might have a bit more side effects. But I'll leave you to Rachel to explain a bit more about this drug and about how to prescribe it.
Thank you, Dr. Neville Azzopardi. A few brief notes on Energast. Energast can also be used to reduce the incidence of traveler's diarrhea. As you can see in the study, the patients who took Energast had only 4.5% occurrence of traveler's diarrhea when compared to 40% in the placebo group. And thus, the people who are receiving Energast rarely had diarrhea in comparison to those who received placebo. The dietary management was started 3 days before the trip and was continued throughout the trip. Thank you for your attention.